Hello everyone. So now we'll start a discussion on sickle cell disease. So sickle cell disease, as I have already discussed previously, this happens because of a point mutation. So this is because of a point mutation in the beta globin gene, and this point mutation happens at the codon number 6, where the glutamine will be converted to valine. So valine will replace the glutamine at the 6th codon of the beta globin gene. Now this will produce a beta globin which is altered, and that beta globin is written as beta S. And when this beta S will form the hemoglobin, that means alpha 2 beta 2 S. This is known as the hemoglobin S. This is known as the hemoglobin S. Now, this condition can be heterozygous, it can be homozygous. Heterozygous means only one allele is affected. So that means there will be some normal hemoglobin A production and some abnormal hemoglobin S production. So that is written as hemoglobin AS. So this is the heterozygous condition, which is seen in 10% of African Americans. And homozygous condition is written like this, hemoglobin SS. Okay. So hemoglobin SS is homozygous condition, which is a more severe condition. And heterozygous is written as hemoglobin AS. In hemoglobin AS, the amount of hemoglobin S that is produced is this. It will be somewhere around. We'll discuss that. Will be somewhere around 40%. So in here, the amount of hemoglobin S that is produced is somewhere around 40%, and rest 60% is normal hemoglobin. Now, before going into the pathophysiology, first we'll try to understand why this sickle cell disease is common in malaria endemic areas. Now, there are two explanations. I mean, actually, these patients, those who have sickle cell disease, I mean sickle cell trait or sickle cell disease, that will give a selective advantage over others against this malaria infection. So there is a selective advantage. What is that advantage? Now, if you see here, this is a normal RBC, and when the malaria parasite is infecting this RBCs, and when the malaria parasite will try to grow inside the RBCs, they'll use up all the oxygen. So gradually the oxygen concentration will reduce. Okay. And also because of the metabolism, there will be production of lactic acid, which will reduce the pH. And we have discussed previously what is the property of this hemoglobin S. And whenever there is deoxygenation, this hemoglobin S, there will be some structural alterations, and these hemoglobins, they'll try to stick to each other, and they will make this polymerization. They'll make this polymer. So this is the process of polymerization that happens whenever there is reduced oxygen tension. And because of this polymer formation inside the RBC, they make the RBC a sickle cell. So that is why the name is sickle cell disease. Okay. Now, what is going to happen beyond this? So once they make this type of RBCs, now this will have reduced deformability, and also there will be some kind of membrane damage. We'll discuss that in detail in the next slide. For the timing, you remember, there will be some alterations in the RBC morphology, some alterations in the membranes, and also this RBCs will become less reformable. So they will be destroyed. So there will be hemolysis of this RBCs. So that means whichever RBC is affected by the malaria parasite, that RBC has a higher chance of getting destroyed. And also, when the RBC becomes sickle cell, it will not allow the malaria parasites to express a antigen over the RBC surface. Usually, these malaria parasites, they express a antigen over the RBC surface. That antigen is known as PFEMP1, that is Plasmodium falciparum erythrocyte membrane protein. Okay, so this is associated with the Plasmodium falciparum, and whenever they infect the RBC, they will tend to produce this protein over the surface of the RBCs. Now, what is the function of this PFEMP1? Now, this will help in adhesion. This helps in adhesion, and if you have studied the pathogenesis of malaria, so basically they will cause this agglutination of RBCs, and also they will cause these RBCs to adhere to the endothelium and cause subsequent damages. So basically, this adhesion molecule is very important for the pathogenesis of malaria parasite. But this sickle cell RBC, because of some membrane alterations, they will not allow this protein to get formed over the RBC surface. Okay, so that will also reduce the effectiveness of malaria parasite infection. So that is how the burden of malaria parasite is reduced in patients with sickle cell disease. Okay, so that is why this patient, those who have this sickle cell trait or disease, they will have a selective advantage over others. So that is why this condition is much more common in areas where there is malaria is endemic. Okay. Same is the scenario with G6PD deficiency and thalassemias. In these conditions also, the infected RBCs will be preferentially destroyed. So that is why they will always keep the malaria burden low in the blood. Okay, so all these conditions are common in malaria endemic areas. Now we'll see what is the pathogenesis, how exactly this sickle septa RBC can cause damage. But before that, let us see some of the factors which can actually increase the risk of sickling. Okay. So I told you previously that whenever there is reduced oxygen concentration, I mean, in the deoxygenated state, these hemoglobins, they will make some surface alterations and they will try to stick to each other, and then they will make this polymer formation, and that will make the RBCs to take the sickle shape or holy leaf shape. Now we'll discuss what are the factors that can actually favor this conformational change. Now, first one is the hemoglobin variants. So it's easy to understand whenever you have a homozygous sickle condition, that means hemoglobin SS. Here you will have around 90% of hemoglobin S. Okay, so homozygous sickle conditions, 90% of hemoglobins will have this hemoglobin S. Okay, so 90% hemoglobin are hemoglobin S. So of course, if you increase the concentration, there is increased risk of sickling. So this is very easy to understand. So maximum risk of sickling is with homozygous sickle condition. But if you have a heterozygous condition, that means 40% HbS and around 60% a normal hemoglobin. So definitely there will be some there will be reduced sickling, because hemoglobin A will not cause any abnormalities. Only the 40% hemoglobin S, they will tend to polymerize. So obviously the severity will be somewhat lesser. It will be around 50% severe compared to the hemoglobin SS. Now we'll discuss about hemoglobin CS. That means this is a condition of compound heterozygosity of hemoglobin C and S. We have discussed previously what is the function of hemoglobin C. Now hemoglobin C, if this is the RBC and we have hemoglobin C, this will activate a channel that is known as the potassium chloride channel. This is the potassium chloride channel. Now, once this hemoglobin C will activate this channel, it will cause the release of potassium and water out of the RBCs. And because of this phenomenon, there will be intracellular dehydration. Because of intracellular dehydration, there will be increased concentration of the hemoglobin S. Okay, so because there is increased concentration of hemoglobin S, again they will try to stick to each other and make the polymer formation. So hemoglobin CS is a condition which also has a increased chance of causing sickling. However, this increased chance, I mean, this increased risk of causing sickling is less compared to the homozygous sickling condition. Okay, so hemoglobin SS will have the maximum risk, followed by the hemoglobin CS, and followed by hemoglobin AS. I hope it is clear. So maximum sickling risk is with SS, followed by CS, followed by AS. Okay. So hemoglobin A is inert. It won't affect. It will not interfere with the hemoglobin S. But whenever you have the hemoglobin C, that can aggravate the condition, because it can actually activate a transporter, that is potassium chloride transporter, which will cause intracellular dehydration, causing increased concentration of hemoglobin S inside the RBCs. So that means whatever condition that can increase the hemoglobin concentration, they can actually cause increased sickling. So that is the second point I wanted to discuss, that in whichever condition you increase the mean corpuscular hemoglobin concentration, that will increase the possibility of sickling. Okay. Then there is another factor. Whenever you have compound heterozygosity for hemoglobin C and S, the amount of hemoglobin S is around 50%. Okay. So we discussed that whenever you have hemoglobin AS, that is heterozygous state, the amount of hemoglobin S is 40%, but in hemoglobin CS, it is 50%. So there is slightly increased amount of hemoglobin S. So these are the two important factors which cause hemoglobin CS to be a slightly severe phenotype compared to the hemoglobin AS. Okay. So the first explanation is it will cause intracellular dehydration. And second explanation is they have slightly higher hemoglobin S concentration. Now, what happens when you have hemoglobin Fs? When you have hemoglobin Fs. Now, we have discussed previously that hemoglobin F will increase the oxygen affinity. It has increased oxygen affinity. So that means they will shift the oxygen dissociation curve to the left. Okay, so this we have discussed in the basics already. So from this you can understand whatever factor which can shift the ODC curve to left, that will increase the oxygen affinity of the hemoglobins. If you increase the oxygen affinity, the hemoglobins will bind to the oxygens and they will not be deoxygenated. So the risk of becoming deoxygenation will be lower. Because they have reduced risk of deoxygenation, there is also reduced risk of sickling. Okay, so if you have this condition, hemoglobin, if you have some kind of hemoglobin F in this patient, so they will have reduced risk of sickling. So they will have minimum risk of sickling. Okay, and that is the explanation. That the usually this hemoglobin sickle cell disease manifests after 6 months of life, because we have previously discussed that hemoglobin F will persist up to 5 to 6 months of your life, up to 5 to 6 months. After then only we will have the beta globin, the predominant beta globin chain, and we will have only the adult hemoglobin. But till 6 months of life, you will have some amount of hemoglobin F. Now that's why till 6 months of life, these patients are usually not symptomatic. Okay, and after 6 months of life, they'll start becoming symptomatic. Okay, so this is the explanation that asymptomatic affected individuals, affected child will be asymptomatic till 5 to 6 months of life. Okay. One point I didn't mention, okay, though I am discussing about the heterozygous and homozygous condition, but I didn't mention, I just mentioned here. So this is autosomal recessive condition. That is why you need both the alleles to be affected, so that they will have severe disease. If one allele is affected, they will have heterozygous condition, and if both are affected, they will have a homozygous condition that is severe. So it has autosomal recessive type of inheritance. Okay. Now, can you tell me any condition where there will be decreased mean hemoglobin concentration, decreased mean corpuscular hemoglobin concentration? Now, I have told you whatever factors that will reduce the hemoglobin concentration, that can also reduce the amount of sickling. So, if the patient has concomitant alpha thalassemia means the alpha globin gene is not produced. If alpha globin gene is not produced, the amount of hemoglobin that will be produced, that will be reduced. Okay, because alpha is needed for all kinds of hemoglobins. Okay, alpha is definitely needed. So if you do not have alpha, they cannot make enough hemoglobins. So the intracellular concentration of hemoglobin will be reduced. So if these patients have concomitant alpha thalassemia, the severity of sickling will be reduced. Okay, so I hope this is clear. Now we have discussed about the hemoglobin variants and how they will affect the sickling. We have discussed about the MCHA and how it will affect the sickling. Now we'll discuss two more parameters. One is the intracellular pH. Now this also we have discussed previously, that whenever you reduce the intracellular pH, what is going to happen? So basically, whenever you reduce the pH, it will cause the oxygen dissociation curve to shift towards right. Okay, so this also we have discussed. So if you reduce pH, that means there will be generation of protons, and these protons can go on bind to the hemoglobins, and they will make the tens form or the T configuration more. They'll convert the hemoglobin to more tens or T configuration, and whenever they will make this configuration, the hemoglobins will have reduced oxygen affinity and they will release the oxygen. So basically, whenever the intracellular pH reduces, there will be deoxygenation, because they will reduce the oxygen affinity. So there will be deoxygenation, and that will increase the risk of sickling. Okay, so intracellular pH, reduction in intracellular pH increase the risk of sickling. This also we have discussed when I told you about the malaria parasite infection. Malaria parasite infection, along with reducing the oxygen concentration, it will also reduce the intracellular pH, and that will cause rightward shifting of the oxygen dissociation curve, more oxygen released from the hemoglobin, more deoxygenation, and more sickling. Okay, now the fourth point is transit time in the microvasculature. Now, if the transit time is increased in the microvasculature, there will be increased sickling. Okay, so this transit time can be increased it can be increased normally. Normally, in the bone marrow and spleen, the transit time is it is increased. I mean, the blood will flow slowly in these two places, bone marrow and spleen. That's why we'll discuss in the clinical features that in sickle cell patients with sickle cell disease, they will have predominant involvement of the bone marrow and spleen. We'll discuss that later. But in some pathological conditions, if there is local inflammation, this local inflammation can increase the WBC counts, the leukocytes, and these leukocytes can actually produce some cytokines. This you must have studied in the chapter of inflammation. So whenever there is inflammation, the WBCs, or the white blood cells, they will produce cytokines which will activate the endotheliums to produce some adhesion molecules. So they will produce some adhesion molecules. One of the important adhesion molecules is P-selectin. Of course, there are various molecules, but I have written P-selectin. There is a reason for it, because now we have some drugs that can actually block this P-selectin, and those are also used in sickle cell disease. So one of those adhesion molecules is P-selectin. Now, whenever they produce this P-selectin, the sickle hemoglobins can actually bind to them. Okay. Now, whenever the sickle hemoglobin is formed, it will also produce some of the adhesion molecules over its surface. Okay, we'll discuss it in the next slide. Okay, so sickle hemoglobin, when it is produced, along with membrane damage, they will also produce some of the adhesion molecules. Now, these adhesion molecules on the surface of the RBCs and the adhesion molecules over the endothelium, over the inflamed endothelium, can actually interact with each other, and there will be more and more accumulation of this sickle hemoglobins. Okay, so that will again cause more sickling, because once the sickle hemoglobins are they are stuck at one place, there will be gradual reduction in the oxygen, because if they are not flowing in the blood, they will not get the oxygen. They have to get oxygen from the pulmonary circulation. But if they are not reaching to the pulmonary circulation, they have stuck somewhere else, they will not get the oxygen, and whatever oxygen they have, it will gradually reduce. So there will be more and more sickling, more adhesion molecules, more adhesion, more microvascular occlusion. That will also increase inflammation. Then there will be more sickling, more adhesion, more microvascular occlusion. So that is actually a vicious cycle that is going to happen whenever the transit time in the microvascular is increased. And this vicious cycle will ultimately lead to complete microvascular occlusion and subsequent infarction of the tissues. Okay, whenever the blood flow is completely occluded, there will be infarction or necrosis of the tissues. Okay, so occlusion complication is a very important complication of these patients, sickle cell disease patients. Okay, again, anyway, we'll discuss that again in the next slide. Okay, so now I hope this is very clear now. These points are very important, and I know to understand all these concepts, you should have watched the video on hemoglobin basics. Okay, so those basics are definitely needed to understand all these things. Okay, these are very simple things, conceptual things. If you understand once, you'll never forget. Okay, so these are all important points. So first of all, you have to understand the hemoglobin variants and how they can affect the sickling. Then the mean corpuscular hemoglobin concentration, then intracellular pH, and then the transit time in microvasculature. And we have also discussed that in bone marrow and spleen, normally there is slower blood circulation. So in sickle cell disease, these organs are predominantly affected. Okay, now we'll see the exact pathogenesis and how it will cause hemolysis and how it will cause microvascular occlusion. So first we'll start with hemolysis. So there are two important mechanisms by which these patients are affected. One is the hemolysis, second one is microvascular occlusion. Microvascular occlusion, I have already told you previously. Now we'll see how exactly the hemolysis happens. Now, if you have this hemoglobin S, and because of various factors, what of those factors I have already told you, due to various factors, they'll make this sickle hemoglobin, they'll make this sickle cell. Now, as you can see here, whenever they will make this polymer formation, they will tend to tether into these membranes. They will tend to tether into the RBC membrane, and because of this tethering, they will cause membrane damage. This membrane damage will activate various ion channels that will cause efflux of potassium and water and influx of calcium. Okay, so this membrane damage will activate certain ion channels that will cause efflux of potassium and water and influx of calcium. Now, this efflux of potassium and water will make it more dehydrated, and influx of calcium will help in forming more and more. It will help in the process of polymerization. So whatever they are doing, they are not good for them. So dehydration and increased calcium actually will enhance the process of sickling. And at this phase, when this condition is reversible for some time, it is reversible for some time. At this stage, if you give enough, if they get enough oxygen, they can be reverted back to normal RBCs. Okay, it can be reverted back to normal RBC. But if this process continues, if the process of dehydration continues, they will have some permanent membrane damage. As you can see here, they will have permanent membrane damage. And these are known as irreversible sickle cells. Irreversible sickle cells. Now you need to understand one thing. If you see in the peripheral smear, if you are seeing sickle cell RBCs, that means those are irreversibly damaged. Those RBCs are irreversibly damaged. Okay. So now what will happen if there is irreversible, if there is irreversible membrane damage? If there is irreversible membrane damage, and if the membrane damage is very severe, if they have very severe membrane damage, they can undergo intravascular hemolysis. If they have less severe membrane damage, they will have extravascular hemolysis. Okay. Now this membrane alterations will make them more rigid. More rigid, they're less deformable. More rigid, less deformable. That means they can have extravascular hemolysis. This we have already discussed previously in detail. But if the membrane damage is very severe, they can be hemolyzed inside the blood vessel also. So they can cause intravascular hemolysis. So actually in sickle cell disease, they can have both intravascular and extravascular hemolysis. Okay. So this is the first pathophysiology that you need to understand, hemolysis. And the next thing is the microvascular occlusion. Microvascular occlusion, I have discussed already that whenever they will make this sickle cell, there will be formation of some adhesion molecules. And these adhesion molecules will go and bind to the inflamed endothelium. They'll go and bind to the inflamed endothelium, and they will get stuck there. Once they get stuck, there will be more sickling because the oxygen will come out of the RBCs. There will be more deoxygenation, more sickling. As there is more sickling, there will be more free hemoglobin production. More sickling means more free hemoglobin production. I mean, more sickling, more intravascular hemolysis, and more free hemoglobin production. Now, this free hemoglobin can actually reduce a substance that is known as nitric oxide. Free hemoglobin can actually bind to this nitric oxide, and it can reduce the intravascular concentration of nitric oxide. This nitric oxide also helps in more vasoconstriction and more sickling. Okay, more vasoconstriction and more sickling. So that is why we also have some drugs. We also have some drugs which can actually increase the NO concentration and cause vasodilation, and those are also somewhat useful in patients with sickle cell disease. Okay. So if this process continues, as I told, it is a vicious cycle. So more sickle cells will come, they will bind, they will get stuck, more hemolysis, reduced NO, more vasoconstriction, more sickling. Okay, so this process will continue, and ultimately they will end up in complete microvascular occlusion. Complete microvascular occlusion, and this is the second important pathogenesis. Microvascular occlusion. Most of the damages that happens in patients with sickle cell disease is because of this microvascular occlusion. Okay, so this will cause tissue infection and various tissue damage. Okay, so in fact they can affect almost any organs, almost all the important organs they are going to affect. We will discuss that one by one. Okay, so these are the two important pathophysiology mechanisms that I want you to remember. Okay, so hemolysis we have discussed, it can be both extravascular, intravascular, and also we have discussed about the microvascular occlusion. Now we'll see the clinical features. So as I told, the brunt of the disease will fall on bone marrow and the spleen. Bone marrow and spleen. What is going to happen in bone marrow? Remember, all these organs, all the damages are happening because of this vaso-occlusion. So in bones, in children, they will have a characteristic finding that is known as dactylitis. Especially in children, they will tend to involve the hands of the hand and feet. So that is also known as hand-foot syndrome, one-foot syndrome. In children, they will affect this hand and feet, and they will cause necrosis and inflammation. So that is known as the dactylitis or hand-foot syndrome. In adults, they will more likely they will cause avascular necrosis. They will cause avascular necrosis. Okay, so this we will discuss when we discuss about the bone pathology. I'm not going to discuss it more here. Also, they will increase the risk of osteomyelitis. osteomyelitis. Okay, and this patients with sickle cell disease, they have a they have a unique pattern of osteomyelitis. Predominantly, they tend to involve the diaphysis. They tend to involve the diaphysis, and also there is increased risk of salmonella osteomyelitis. Okay, so if in the exam, if they are asking about, they are telling about salmonella osteomyelitis, then you have to think of sickle cell disease. Okay, usually osteomyelitis is caused by Staphylococcus aureus, and usually they affect the metaphysis. But patients with sickle cell disease, they have a unique pattern. They predominantly affect the diaphysis, and salmonella has, salmonella is more likely to cause osteomyelitis in these patients. Of course, in these patients also, Staphylococcus aureus will cause osteomyelitis more commonly, but salmonella predominantly affect the patients with sickle cell disease. Okay. Anyway, again, this we'll discuss more when we'll discuss about the bone pathology. Then what is going to happen in the spleen? First, we'll discuss about the bone and spleen, then we'll go to the other organs. So, what is going to happen in the spleen? So, initially, because of this extravascular hemolysis, there will be splenomegaly like any other condition. So, initially, there will be splenomegaly. But ultimately, because of this multiple infection, because of this vaso-occlusion and multiple infection, and if this process continues, ultimately all these patients will go for autosplenectomy. They will go for autosplenectomy. It's a very important point to understand. So you need not do splenectomy for this patient, because for all these patients, the spleen will undergo autolysis. Okay, spleen itself, by itself, it will become fibrosed, and it will become, and this condition is known as autosplenectomy. So spleen will be the functionality of the spleen will be lost because of this multiple infection. Okay, so once the spleen is not functioning, there is increased risk of opportunistic severe infection. Okay, opportunistic infection, there is increased risk of, OPSI is known as the overwhelming post-splenectomy infections. So there is increased risk of infection, especially with capsulated organisms. Capsulated organisms like the pneumococcus, Haemophilus influenza. So that is why these patients, if the patient is diagnosed with sickle cell disease, we give them vaccinations, and also we give them penicillin prophylaxis to prevent against this infection. Okay, so especially whenever there is autosplenectomy, or whenever you remove the spleen, there is always increased risk of infection against the capsulated organisms. Okay, anyway, that also we'll discuss when we'll discuss more about the spleen. Okay, so this is about the bone and spleen. Now, what is going to happen in the kidney? And kidney, if you see, it has a cortex and it has a medulla. In the medulla, definitely the oxygen concentration in the medulla is less, and the tonicity is high. The medulla is hypertonic area. Medulla is a hypertonic area, and because of this, there is increased risk of sickling in the medulla. So there is increased risk of sickling in the medulla. Now, what this is going to do? So this is going to damage the loop of Fenley. This is going to damage the loop of Fenley of the tubules, of the renal tubules. So that will ultimately cause, now this kidney will lose the property of, it will lose the ability to concentrate the urine. So now these patients cannot concentrate the urine. So that condition is known as hypostenuria. Hypostenuria. So they lose the ability to concentrate the urine. Also, there is increased risk of renal papillary necrosis. Renal papillary necrosis. This also we'll discuss more when we discuss about the renal pathology. Then what is going to happen in the lungs? In the lungs, they will have a very characteristic, life-threatening condition that is known as acute chest syndrome. Acute chest syndrome. Acute chest syndrome has multiple, these are actually multifactorial. It is not only due to vaso-occlusion. Vaso-occlusion is one of the mechanisms which can cause infection, but this can be actually aggravated or precipitated by some kind of infections or some kind of fluid overload. Sometimes it is maybe because of some fat embolism. So there are various factors. So basically, they will all these things in these patients can actually cause acute chest syndrome, and it is definitely it's a life-threatening situation. Okay, acute chest syndrome. So usually these patients will present with acute onset respiratory distress, and if you do the chest X-ray, you will find the bilateral infiltrates. Okay, you will find bilateral infiltrates, many of these cases, we do not find the exact cause, but we have to treat the patients with all the measures. We have to treat for the sickling, we have to treat for the infection part, and we also have to look for the evidence of thrombosis and necrosis. Okay, so again, that's a very important and life-threatening condition. Okay, now in the penis, but because of this vascular occlusion, they can actually cause a condition that is known as priapism. Priapism is actually unwanted, persistent erection of the penis, unwanted persistent erection of the penis, and this is also a very, I mean, it's not a very good condition to have, because if you don't treat this condition aggressively, the patient can go into permanent impotence. Okay, so that is priapism. Similarly, it can also affect various other organs like cardiovascular system. It can cause cardiovascular, I mean, it can cause myocardial infarction. It can affect the central nervous system, causing cerebrovascular accidents, like, I mean, the ischemias, and also there is increases the hemorrhage. So various cerebrovascular accidents they can cause. In the retina, because of this ischemia, they can cause proliferative retinopathy. Proliferative retinopathy. Okay, so these are the various, I mean, various complications. Apart from that, there are so many other complications that also can happen, but these are important complications because of this vaso-occlusion. Now we'll see some other complications. One more complication is sequestration crisis. Sequestration crisis happens whenever the spleen is enlarged. I mean, I told you initially these patients will have an enlarged spleen because of this extravascular hemolysis. Gradually, there will be autosplenectomy because of this multiple infarctions. But whenever, I mean, if the patient is in splenomegaly state, if the patient has splenomegaly, in that situation, sometimes they can go into sequestration crisis. There means there is sudden severe increase in activity of the spleen. So activity of the spleen will severely increase, activity and size will severely increase. Now the spleen can take up all the blood from the circulation. It can actually take up all the blood from the circulation. So this is actually, if you ask me what is the most dreaded complication or most life-threatening, it's actually sequestration crisis. Because if you have vaso-occlusion crisis, for example, if you have acute chest syndrome, that will give you some time to intervene. But in this sequestration crisis, there will be severe, I mean, a severe intravascular volume depletion, because the spleen will gradually increase and they will have a sudden increase and sudden removal of the body fluid or the blood from the circulation. So there will be severe intravascular volume depletion leading to hypertension, shock, severe anemia, and these patients can die in minutes. Okay, so sequestration crisis is very dangerous. They can also have aplastic crisis. This I have already discussed, so I'm not discussing again. This I have already discussed when I discussed about the hereditary spherocytosis. Aplastic crisis can happen in any patients with hemolytic anemia. This happens because this pro-erythroblast or the erythrocytes precursors, they will tend to present an antigen, that is the P antigen, to the parvo B19 virus. Parvo B19, once it identifies this P antigen, they can infect this pro-erythroblast and they can form the inclusions, which you can see in the peripheral, I mean, you can see in the bone marrow as a giant pro-normoblast with a viral inclusion that is also known as the lantern cell. Okay, so that is because of parvo B19. Usually this condition is self-limited. Until the time the patient recovers, you have to give support. Support. Now, a very common question that is usually asked, like if the patient is having, for example, sickle cell anemia, and there is sudden severe decrease in the hemoglobin. So we have most commonly two possibilities: either there is increased hemolysis, or there can be a possibility of aplastic crisis. Now, from the CBC, how can you predict whether it is due to hemolysis or whether it is due to aplastic crisis? Now, from the CBC, actually, you can look for the retic count. Now, if it is due to hemolysis, if the fall in hemoglobin is due to hemolysis, there will be increased retic count. And I know you all must be knowing how to count, how to do a reticulocyte index, how to calculate the reticulocyte production index. You have to correct it for the anemia, and also if there is polychromasia, you have to divide it by 2. So if you do all those things, and if you found that retic is still high, that means this patient is having hemolysis. But if the retic count is low, then you think of this aplastic crisis, because in aplastic crisis there is halting of the process of erythropoiesis, because the viruses are affecting the erythroid precursors. So retic count will help us predicting whether it is due to hemolysis or whether it is due to aplastic crisis. Now, sometimes this patient can also have leg ulcers, and these leg ulcers usually these are found near the medial and lateral malleolus. These are described to because of stagnation of the blood, and this condition is also, I mean, it's also common in various other hemolytic anemias. Okay. So that is about the clinical features and complications. So how will you treat these conditions? You can give a drug that is known as hydroxyurea. Hydroxyurea, basically it has two important mechanisms. One is it can actually increase the hemoglobin F production. And I have told you the effect of hemoglobin F. Hemoglobin F will cause increased oxygen affinity, shifting of the oxygen dissociation curve to the left. So that will reduce the deoxygenation and reduce sickling. So hydroxyurea can actually increase the hemoglobin F. And it can also reduce the WBC counts. It can also cause myelosuppression. It can cause myelosuppression because it inhibits the ribonucleotide reductase. Ribonucleotide reductase is required for your nucleotide synthesis. And if hydroxyurea is inhibiting that, there will be decreased production of this. They can actually cause bone marrow suppression, and in the same process, it can reduce the WBC counts, number of WBCs. And I have told you previously that the WBCs, they make the endothelium more inflamed, more adhesiveness. So all those things will be reduced if you give hydroxyurea. So that is how hydroxyurea is very useful in patients with sickle cell disease. But actually, hydroxyurea is discovered as anti-neoplastic, I mean, cancer chemotherapy agent. But when they used in these patients, they found that these patients have significant improvement in symptoms. So since then, it is being used in patients with sickle cell disease. Also, you have to give them these patients blood transfusions. You have to give these patients blood transfusion as required, and you have to keep the hemoglobin S concentration as low as possible. Sometimes you need to do exchange transfusion whenever the hemoglobin S concentration is very high, and if you want to reduce the concentration, you can remove the blood and you can give fresh blood. And also, we have, currently we have hematopoietic stem cell transplantation. Gene therapy is also developing. I mean, those things are newer things. There are also some disease modifying drugs. Also, sometimes L-glutamine is used. The exact mechanism, we're not very sure, but this is also a drug that is being used. And there are certain newer drugs I'm not going to discuss in this particular lecture. That's beyond the scope of this lecture. So those things we'll discuss later when we'll discuss about the pharmacology. Okay, so we have discussed about the clinical features and some of the important modalities of treatment. But what you are going to see actually in the peripheral smear, I mean, how will you diagnose? Ideally, I should have told the diagnosis before and then the treatment, but anyway, it's fine. So what are the diagnostic modalities? First, we'll see the morphology. In peripheral smear, what you are going to get? You are going to get this sickle cell cells. So these are all sickle cells. I mean, these are irreversibly sickled cells. ISCs, irreversibly sickled cells. That means there is permanent membrane damage. And I have told you, if you're finding them in the peripheral smear, these are irreversibly sickled cells. But apart from that, you will also get this cell that is known as a target cell. This is a target cell. Now, target cell can also happen in various other conditions. Target cell will look something like this. It will be something like this. That means there will be a central, central area of the central dot-like area in the RBCs. Now, this can happen because of excessive membrane or because of dehydration. In these patients, in sickle cell disease patients, it is usually due to dehydration. Some of the hemoglobin, they will tend to accumulate in the center as a central dot. So that is known as the target cell. These are also seen in various other conditions. We will discuss them later. Okay, so you are going to get this irreversibly sickled cell, not in all patients, but if they have this irreversibly sickled cells, then you can also find this, and you will also get the target cells. Okay, now if you see this peripheral smear here, if you see this smear, this is very unifying. So, I mean, this is a very important, very interesting spotter question. Many times in the exams or in the quiz, they ask this question. They will give a history of patients with sickle cell anemia, and they will give this peripheral smear. So what you're going to appreciate that you can see that there are some small bluish dots over this RBCs, small bluish dots over this RBCs. Now, what are these dots? I have told you when I discussed about the process of erythropoiesis, I have told you that whenever this reticulocytes will come into the circulation, they will have some chromatin material over them, and that is why they are named as reticulum, because chromatin network is known as the reticulum. That is why the name reticulocyte. Okay. Anyways, so reticulocytes, when they come to the circulation, they will have some of these chromatin materials. And I told that time that spleen has an important role in removing those chromatin materials, because splenic macrophages will realize that these are not normal for RBC. This is not normal for RBC. RBC should not contain any nucleus. They should not contain any chromatin materials. So if the reticulocyte is containing these things, then spleen will recognize, splenic macrophages will recognize them, then they will remove these chromatin materials. But in these patients, once they undergo autosplenectomy, as you can see here, the patient has undergone autosplenectomy because of these multiple infarcts. Okay, so I have discussed previously that spleen will have, initially there will be increased size, I mean splenomegaly, and gradually there will be autosplenectomy. Okay, so once they undergo autosplenectomy, now the spleen cannot remove those chromatin materials from the reticulocytes. Now these chromatin materials will tend to aggregate and they will make these inclusions. And these inclusions are known as Havel-Jolly bodies. Havel-Jolly bodies. Okay, so this is again a very, very, very important question. So anytime they will give this history of, anytime they give the history of a sickle cell disease and they give this smear, the answer has to be Havel-Jolly bodies. Havel-Jolly bodies. Now, this kind of similar dot-like structures we have also discussed when we discussed about the Heinz bodies in patients with G6PD deficiency. But what is the difference? I have told you that Heinz bodies are recognized on supravital stains like crystal violet, but Havel-Jolly bodies can be seen in this Zimsa stain, the normal Romanowski stain, and the most common Romanowski stain that we use is Zimsa stain. We'll also discuss the stains in a separate lecture. But for the timing, you remember the normal peripheral smear is made with Jenner Zimsa stain, and in this Zimsa stain, you can appreciate the Havel-Jolly bodies. But Heinz bodies are usually identified on supravital stains, that is the crystal violet. What you're going to get in bone marrow, it's very simple. If there is hemolysis, there will be increased erythropoiesis, there will be increased erythrocyte precursors. So this again, I'm not going to write because these things you already know. There will be increased erythrocyte precursors. And whenever there is excessive hemolysis, there is extramedullary hematopoiesis. We have discussed whenever you have extramedullary hematopoiesis, this can happen. This can involve the liver, the spleen, and also there will be increased widening of the medulla in the skull bones and face bones. And those things also we have discussed that they will produce this crew cut appearance. Whenever there is increased hemolysis, they will cause crew cut appearance. So in extramedullary hemolysis, I'll just write it again. So it can cause hepatosplenomegaly, but this splenomegaly, it is transient. Gradually there will be autosplenectomy. Hepatosplenomegaly also they can sometimes involve the lymph node. And these are also associated with crew cut appearance. Because the skull bones, there is increased bone marrow, increased activity of the bone marrow in the skull bones, which will cause this crew cut appearance. This we have discussed previously. Also, there is increased activity in the facial bones. Okay, facial bone. And involvement of these facial bones will cause a characteristic facie that is known as chipmunk facie. Chipmunk facie. Now, many times, if you go to the OPD, at least to the medicine OPDs, and sometimes your professor will tell from seeing the patient from a distance, they can tell that this patient is having some kind of hemolytic anemia. Sometimes they can tell, and that is because they can see this chipmunk face. The chipmunk face is actually the central part of the central parts of the face is it is depressed, and the surrounding part, the maxillary bone, the frontal bones, they are excessively enlarged. So that is known as the chipmunk face, and also there will be some jawbone enlargement that will cause dental malocclusions. We'll see this. We'll discuss this again when we'll discuss about the thalassemia. Now, these patients can, any condition that is causing excessive hemolysis, excessive activity of this bone marrow, excessive extramedullary hematopoiesis, that can cause this chipmunk face and clear cut appearance. Also, you will have other features of extravascular hemolysis. No need to tell that extravascular hemolysis means you will have this hyperbilirubinemia. You will have this gallstones, and all those things can be seen. Okay, so these are all the findings that we are going to get. But how will you confirm the diagnosis? Remember, peripheral smear is not confirmatory because many times you are not going to see this sickle cells. Previously, there was a test that is used known as sickling test. Okay, just for the sake of completion, I'm telling, but nowadays, no. Usually we don't do sickling test to confirm the diagnosis because we have better alternatives. I'll come to that, but just for the sake of completion, if they ask you how you do sickling test is done by sodium metabisulfite. Sodium metabisulfite. Sodium metabisulfite. I mean, this will cause reduced oxygen content, and that will cause sickling of the RBCs, and then you can appreciate the sickled RBCs. So that is something which was done previously, but now all these patients are being diagnosed with hemoglobin electrophoresis. I mean, high performance electrophoresis. Now, alkaline, yes, cellulose acetate gel electrophoresis is not usually used. What we prefer always is hemoglobin HPLC, high performance liquid chromatography. Okay, so in this, what you're going to say is, as you can see here, you can see the various peaks, and all these peaks will correspond to a particular type of hemoglobin, and depending on their retention time. Now, all those details are not important. What is important is what is the amount of percentage of hemoglobin, various hemoglobins that we are going to get. Again, I will not discuss these things in great detail because it's not important at this point of time. So if you see the S window, so you are having 37.4%. That means hemoglobin S is around 37.4%. So this is nearer to around 40%. So this condition is hemoglobin AS. We have discussed previously. In hemoglobin AS, the amount of HbS will be around 40%. So this is a heterozygous condition. If you see here the S window is having around 75%, 75 to 80%. So this is the condition of hemoglobin SS. So around in these patients, around 75 to 90% of hemoglobin can be hemoglobin S. So this is the condition of hemoglobin. I mean, homozygous hemoglobin, homozygous sickle cell disease. Okay, so what we read generally is if the hemoglobin S is less than 40%, I mean less than equal to 40%, most of the times it is heterozygous, and if it is more than 40%, more than 50%, it is usually the homozygous condition. Okay, I mean there are other variations also. Sometimes there may be sickle beta, there can be some additional alpha component, but all those things are variations. To start with, we will just read the simple things. So this is the first one is hemoglobin AS, and the second one, I mean, it is heterozygous condition, and the second one is the homozygous condition. And with that, I think okay, with that we have completed the sickle cell disease. In the next section, we'll discuss about the thalassemias.